So welcome everyone to our Patient Information Day. And my name is Maureen O'Donnell, and I am the host for today's session. And we've got a lineup of really interesting speakers. Before I introduce them, just a really quick couple of things for the agenda. There is a study that's currently being done on mental health in patients with lung fibrosis. There's more information out on our latest news on the website. If you'd like to participate in that study, it just requires that you fill out a questionnaire. That's the only requirement for it. Won't take you but just a little bit of your time, and it would certainly help advance the research in lung fibrosis if you could participate. The deadline is May 15th, so anytime before now and May 15th would be great. Another thing that we've got coming up is our resilience course for patients. It's a 6-week course with a variety of topics that we're going to be talking about under creativity. It should be fun. It should be a really enjoyable and interesting experience. So we hope that you'll be able to join us for that. And if you are interested in it and haven't yet registered, you can register by going to info@ilfa.ie. Just send them and just send Kelly an email and she'll get you registered. And then last but not least, this event, our Patient Information Day, as all of our events in the Lung Fibrosis Association, are paid for through the generosity primarily of individual donors. So if you would like to donate to ILFA, just go to our website. There's a donate button there. Click on that and you can donate. Even 10 euros is great. More is even better. You could also send a check or a postal order to our address on Brunswick Street. And then if none of those things work for you, then maybe check out our Facebook page where there's a lot of fundraisers and you can participate in one of the fundraisers that we have upcoming. So with that done, I just wanted to introduce our first speaker today. It's Frank Brannigan. Frank is a patient with lung fibrosis, and he wants to tell his story to inspire us all through the session today. Welcome, Frank.
Thank you very much. Thank you very much. Yes, Frank Brannigan here. I'm a lung fibrosis patient, and how it all came about really was back in 2006. I had this short, dry cough, not particularly noticeable to me, but my wife constantly remarked on it, and she said, in particular, when you're on the phone, you start to cough. So obviously my breathing method while speaking on the phone was slightly different to normal. So my GP referred me to a respiratory consultant who sent me for a CT scan. And at that time, they decided that there was nothing particularly sinister and nothing was done about it. So they thought maybe it was stress related to my business, running a business. And many years later, back in 2007, 8, we lucky enough to sell the business, and along with that went the stress. However, the cough didn't disappear, so it slowly got worse, and then right up until 2018, we decided that I'd better go and have this checked out again. So in 2018, I went again to the consultant and another CT scan, and it was confirmed then that I had idiopathic pulmonary fibrosis. I had never heard of the disease. I didn't know what it was. And when it was explained to me, and the prognosis was explained to me, and the fact that it was a terminal illness, I was shocked. I was absolutely devastated. My wife and myself had no idea that this was going to be the outcome, and we just couldn't understand where it came from. All the usual questions came out, and it was explained to me that the fact that it was idiopathic meant that it wasn't genetic, it wasn't environmental. So I was never a smoker. I was always quite fit. I played sport, played tennis and golf, there was nothing I was exposed to in terms of the environment I worked in, no acids or formaldehyde or asbestos or anything like that, and that it was basically just one of those things. My immediate concern, of course, was my two children. Were they likely to get the disease, or would they have the gene? It was explained to me that IPF was mainly sporadic and that it's unlikely that it would be passed. There are cases of familial idiopathic pulmonary fibrosis, but they would be rare enough. So that did give me some ease and helped me to accept the devastating news. And to be honest with you, it's still a concern to me. Obviously, my two adult children now are healthy, but I'm hoping that there's nothing in the genes that will pass through to them. Maybe the doctor couldn't allude to this when he makes his presentation. The prognosis of 3 to 5 years, obviously, post-diagnosis is changes and is difference with depending on who the patient is. And of course, I was diagnosed now in 2018, so that's over 7 years ago. And the disease has progressed. It has progressed slowly, but not in a slow slide, but more or less in dips. It would hold steady for a while, and then I'd see a marked disimprovement. My consultant decided that he would put me on a retardant medication. There was two available. There was pirfenidone or OFEV. We decided for me to go on OFEV, which is branded in Ireland under nintedanib, and mainly because the other medication meant that your skin could suffer as a result of exposure to sunlight and whatever. So I do like the sun, I do like being out. So we decided on the OFEV or nintedanib. It's a tough medication to be on. Any patient who is on it will understand. A lot of stomach upset, a lot of diarrhea. It affects your whole lifestyle, where you go, how far you'll be away from a bathroom. Can I play 4 hours of golf? Can I go for long walks, etc., etc. Everything is geared by that because it's a very, very severe medication, and it also brings with it extreme tiredness. So stomach upset is the main thing, and then tiredness comes with it as well. Exercise is difficult too because you're getting tired. It's getting more and more difficult to exercise. Over the next 5 years, my condition did drop. I'm not sure if the OFEB helped, but you have to do everything you can to make the best of the life that you have. So we took it, and maybe I did get the extra 5 or 6 years in the interim as a result of that medication. I noticed that the condition worsened significantly over the years, and right down to where I am today, which is, I would say, stage 3. So basically, I need oxygen 24/7. I have 10 to 12 liters of oxygen delivered to me every 10 days or so. That allows me, when I'm out, to have my oxygen. Here in the house, I have 4 concentrators. I have one downstairs here in the living room. I have one upstairs for nighttime. I have a portable concentrator that I can take with me whenever I need to travel and stay overnight somewhere other than this house, one that will fit into the car. And then I have a very small over the shoulder concentrated Inogen 6, which will allow me to leave in the car, each charged by the 12-volt charger socket in the car, and that allows me to drive and to get out of the house. Really, I suppose the big disappointing thing for me is that my activity has been hugely restricted over recent times. And as we went through the process of going on the medication and the condition getting worse and worse, the follow-up pulmonary function tests led my consultant to recommend me for consideration for a lung transplant with the matter. He wrote a letter requesting that. I was lucky enough to go and get all the tests, and very lucky enough to be accepted onto the lung transplant list in the matter. Once I got on the lung transplant list, Linda and I decided it was now time to tell our family and friends. I hadn't mentioned anything to them before that because there was literally nothing they could do, and no point in worrying them when it was a fait accompli. But at least this time I was able to explain to them what the condition was and that there was the possibility of a lung transplant. So I was able to couple the bad news with a little bit of hope that the lung transplant was on the horizon. I've been on the transplant list now since July 23, and I was 37 months on the list before I received any call to attend. So on the 23rd of February this year, I got a call, and 30 minutes later, there was an ambulance at my door, and I was brought into the matter. There, I went through the battery of tests, the ECG, the X-ray, bloods were taken, the questionnaire filled out, showered and gowned up and ready for theatre. But unfortunately, the donor lung wasn't suitable for transplant that day. A couple of weeks later, on the 2nd of March, I got my second call. And again, I went, and becoming familiar with the paramedics in the ambulance at this stage, went and I said, well, this could be it, and went through the whole thing again. And again, unfortunately, the lung wasn't suitable. A few days later, again, on the 19th of March, I got my third call. And again, ambulanced into the matter, went through all the battery of tests again, gowned up and ready to go. But again, unfortunately, not a runner. I was taken in on the 15th of April for the 4th time. And unfortunately, the lungs went to the other candidate who needed both lungs to survive. The one good thing that came out of that was at least someone got a transplant that day. And I was delighted for he or she that at least he and their family would get the benefit of that. I'm living now with oxygen. I'm waiting for that call, and hopefully it'll come soon. My movements are very restricted. I'm able to sit here and talk, but as soon as I get up to move and definitely to walk, the breathlessness comes very, very quickly. I have oxygen monitors everywhere. I have one in my pocket, one beside the armchair, one beside the bed, one in the car, and I'm constantly checking my blood oxygen levels. I try to keep them at 94%, but they do drop, and they drop very quickly. So I have to be ready to respond by increasing my oxygen. and stopping and breathing and taking my time, in particular going upstairs. Take a few steps, I have to stop and wait for the oxygen to come back, take a few more steps. If I don't, I get extremely breathless, and also the bouts of coughing become extremely severe. The coughing hasn't gone away. In actual fact, it comes now in bouts, and so much so that the oxygen levels drop very, very, very quickly. So that is a big concern for me. Brings me right up to date. It brings me to where we are. I have a great support from my family and friends. I obviously don't like asking people to do this or do that for me, but they're only ready, willing, and able to do so. So I'm confident in the transplant team in the matter, that they'll only transplant organs that are A1, and that gives, even though I haven't received one to date, it gives me great confidence that when they do, they will only do the best. So I have nothing but utmost confidence in the transplant team in the matter, and I'm ready, willing, and able, and literally to put my life in their hands. So that's where I am today. Thank you.
Wonderful, Frank. Thank you so much for that story. It was an excellent description of the journey that you've had thus far, and we all certainly hope that you will be getting that lung transplant soon. So thank you so much. I really appreciate it. Great. So next, I think what we are going to do is so sorry, my screen's gone a bit weird there. Next, what we're going to do is introduce Professor Cormac McCarthy. Now, Cormac, are you with us?
Yeah, sorry, I am. Yeah.
Wonderful. Thank you so much, Cormac. And just to say, Cormac, if you've got about 20 minutes, if that's okay. Cormac is a associate professor at the UCD School of Medicine, a consultant in respiratory medicine at St. Vincent's University Hospital. And today he's going to be talking to us about IPF and update on the recent clinical trials. Okay?
Right, yeah. I'm just going to share my screen. It says someone else is sharing at the moment, Maureen, so I don't know. Share.
Are you not able to hit the share button?
Now it's working. Sorry, yeah. It just.
Okay, great.
Let me just see. There we go. Can you see that?
We sure can. It's not in presentation mode though, so if you could put that in presentation mode, that would be great.
Now, yeah.
Nope, we're still seeing the slide deck.
All right, hang on.
You may need to share your entire screen, perhaps.
Maybe, yes. Okay. How about that? Is that better?
It's perfect.
Okay. So thanks for inviting me to speak. So I was asked to give a talk on IPF, but I felt a lot of that has been discussed before on some of these patient information meetings. So I wanted to give an update on some of the recent clinical trials and some of the activity. There's a lot of interesting and emerging activity in this area, which is really exciting, and hopefully we'll have newer treatments coming as well as some of the established treatments, which I just wanted to kind of give an overview of what's happened in the past and a little bit of what's new in the last year or so. So just very briefly, I think a lot of people on this call will know, but when we talk about pulmonary fibrosis, what is it? It's part of a larger group of what are called interstitial lung diseases, and there's over 200 of those. And most of them are characterized by this inflammation or scarring in the lung. And that happens when you get injury or damage, affects the alveoli, which are the air sacs of the lung, and affects the space in the tissue. Sorry, oh, it was not coming up. Here we go. And so when an ILD includes scar tissue, we call it pulmonary fibrosis. And What's meant to happen in the lung normally is you have this intricate network of airways called bronchi and bronchioles, and they go to these little sacs called alveoli at the end, where we exchange oxygen, where we exchange gas, oxygen in and carbon dioxide out, with this very thin layer between the bloodstream and the air coming into these sacs. And this is called the interstitium, this network. And what happens in fibrosis, this becomes distorted. And when we talk about it, things that can affect the lung, you know, if you think of the lung as a sponge, it should be like a moist sponge like this. This is a normal lung. This is after at a post-mortem, but it should be like a moist sponge. It's able to expand and contract, and there's enough fluid there, but then you can get air across it. Sometimes when people have what's called pulmonary edema, or they get fluid in their lung from heart failure or heart dysfunction, it becomes wet and it can't perform it appropriately. And in fibrosis, what happens is you get these levels of extra layers being deposited, and essentially your lungs get all of this extra tissue being deposited, so they cannot exchange the oxygen, and it becomes dried out like this kind of sponge here. And essentially that's what fibrosis looks like. And things that can affect this can be chronic, happen over many, many years. They can be acute. You can have some scarring, some inflammation, some infections. So when we talk about interstitial lung disease, we talk about lots and lots of different conditions, not just one condition, not just one cause of fibrosis. And it's important to remember that. But then also some things have similar treatments and some things have different and similar causes. So going back to this graph that I showed you a minute ago, this little cartoon, this is what your normal alveolus should look like. This thin layer here where we have the interstitium. And then when you get this scarring, then it makes it difficult to exchange oxygen. And then that causes this disruption. And that's what happens in pulmonary fibrosis. You get this thickened alveolar wall, this extra tissue. And that causes the ability of your lungs to exchange oxygen to be impaired, which then increases the work of breathing, increases the presence of breathlessness and other respiratory symptoms. So again, you know, this is just to reiterate, these are fibroses. So I'm not going to go into a lot of the detail, but there's lots of different mechanistic things that occur. You get extra tissue layered down, you get extra blood vessels forming. We get a lot of all of these cells behaving, and they cause all this extra activity in these specific cells in the lung. But the reason it's important that we know this is this has led to us to understand which potential treatments we can target and how can we improve care for this condition. So this is a busy slide, and again, I'm just going to show you, we originally thought that you got this inflammation and there was injury and that caused fibrosis. We now know that there's likely repeated stimuli, something in the air, something in the environment, some other injury, and this causes repeated injury, causing inflammation, and some people are genetically predisposed, and then that leads to this aberrant wound healing. So like the way if you had a scar, and some people get a scar on their skin from a cut, some people scar easily, they may have an inherent predisposition that, and then similarly, some people may have an inherent predisposition and get fibrosis in the lung. But this is a very complex process. There are lots of different factors, and I'm not going to go through these, but there's lots of different cells involved in the lung. There's lots of different processes, lots of different signaling pathways, and we know an awful lot more about this than we did many years ago, which allows us to understand the biology, which allows us to potentially have new treatments, which I'm going to talk about in terms of the clinical trials and the drugs that we may or may not be able to use in this condition. And it's confusing. I just showed this line. So these are the historical terms used for IPF before consensus. And you can see here, there's loads of different names, and even still people call it different things. And we call it IPF, or idiopathic pulmonary fibrosis. But you can see all of these names for years: cryptogenic fibrosing alveolitis, diffuse interstitial pneumonitis. These are old terms. Some of them are still used, like usual interstitial pneumonia. But again, it's confusing, and you know, part of that is what is the driving features, because we don't fully know, and it led to a lot of confusing names. So when we talk about IPF, if you come to a standard interstitial lung disease clinic, or a busy clinic like mine, or like some of the other physicians on the call, about 1 in 5 of our patients will have idiopathic pulmonary fibrosis. And then it's fairly evenly distributed across these other conditions: chronic hypersensitivity pneumonitis, some connective tissue disease related to interstitial lung disease, and then sarcoidosis. And why is that important? Because, and I'll come back to that in a moment. Well, so the reason we talk about idiopathic pulmonary fibrosis, it's the most common form of pulmonary fibrosis. It's progressive. And for many, many years, the mortality was about 70% within 5 years of diagnosis. This has changed a little bit now with treatments, and we don't know what causes this. It's synonymous with this biopsy-proven UIP, and you get this scarring of the lungs where you get loss of your lung tissue, and you see this what's called honeycombing, where it looks like a honeycomb here in this CT scan. And that loses, you get loss of your alveolar tissue and an inability to exchange oxygen appropriately. And how do we diagnose it? So you're not that straightforward anymore. You need a multidisciplinary team. You need a CT scan, and you need sometimes a biopsy. But depending on how classic the CT scan is and ruling out other things, we need to take this multidisciplinary approach where we go through this pattern. And again, the reason I show this is because to determine whether someone has IPF or not is important, because the treatment will or will not differ about what evidence we have for it. And what we mean by evidence is what trials have been done that support treatment. But it's difficult to differentiate. And so again, this is pulmonary fibrosis, and all of these conditions I just showed that come to our clinics, any of them can have pulmonary fibrosis. IPF always has pulmonary fibrosis, but some of these other conditions can behave like it. They can present similarly. They can have a CT scan that can look like it. So again, differentiating these is sometimes difficult and sometimes important, but other times they may have similar treatments. So one of the things is this overlap of these progressive fibrosing. What we know is they probably have a similar mechanism, some similar biology, why they get fibrosis. They get decline in lung function over time. You get worsening symptoms over time. And then it can be associated with earlier mortality than someone who doesn't have fibrosis. But some of the unknowns are which drugs work for which underlying condition, who should get treatment, and then what are the markers or predictors of who's going to progress. So these are the things we don't know, even though they commonly have fibrosis, and all of the ones with fibrosis, do they behave the same? One thing that's important is on the CT scan, if you have what's called honeycombing. So in IPF, you get honeycombing, you get traction bronchiectasis, you get some of these other findings. But if you have honeycombing in IPF, and if that's present in some of these other conditions that have fibrosis, pulmonary fibrosis with honeycombing, again, the prevalence is similar, but if you have honeycombing present, that has a worse prognosis than not. So even if someone doesn't have IPF, they have a different fibrosis. If they have honeycombing, then that's associated with a worse outcome than someone who doesn't have honeycombing. So then that begs us to think, should we think of anyone who has honeycombing or anyone who has that type of fibrosis, should we treat them similarly? Should we look at the trials the same way? And that'll have implications for some of the studies I'm about to show you. So I want to take a step back. And if we go back just over 20 years ago to when we got the ATS and European Society guidelines for how do we classify patients with interstitial lung diseases, this is how it was done. This is from 20-something years ago. And you can see here, we looked at known causes. So you're associated with autoimmune condition, or unknown causes. And these are the green, the idiopathic causes. And down here is IPF, and then some of these other rare ones as well. So again, at the time then, we didn't really have much to treat. Okay, so the treatment 20 years ago was, there was no evidence for any treatment. People were commonly given immunosuppression. Often they were given steroids or azathioprine. And then lung transplant was available to a small minority as a cure. But again, there was no evidence base. So in 20 years, we've come a long way though. These are the number of trials up until 2017, because I don't have an updated figure from this, because there's been an even huge number in the last 8 years. But over that 25 years, you can see here the number of trials being done, and the size of the circles shows how big the populations, how big the studies were. So there was a number of small studies, a lot of the same medications being looked at over time, over 25 years. These are the studies that were being done. And up until 10 years ago, none of these showed any efficacy. And then we had a couple of studies, which I'll show you the details on, that led to effective treatment that we know slow the progression of this disease. But I want to show you just a very brief overlap. This is a study called PANTHER. This is where we looked at patients who got immunosuppressive therapy or no therapy. And the patients who had immunosuppressive therapy, steroids and azathioprine, they did worse. They had a higher rate of death than those who got no treatment. So this put an end to the idea that we should use azathioprine and steroids. Then the two trials that made a big leap in IPF were IMPULSES and ASCEND. And I'm going to show you a little bit of the detail of this, but both of them showed that these medications, nintedanib and pirfenidone, they slowed lung function decline over time. And since then, we've had several other successful trials in connective tissue-related ILD. So again, there's been some that showed no effect of cyclophosphamide, similarly with MMF. But then nintedanib, the same drug we use in IPF, showed that this was effective in scleroderma-related ILD. And then some specific therapies for some of these drugs also were effective. And then we did Other ones like inbuilt, which I'll show you the data on, where I looked at lots of causes of fibrosis, not just IPF, but fibrotic ILD. That was what's called progressive fibrosing ILD. And regardless of the cause, whether it was unclear, whether it was connective tissue related, again, these drugs were effective. And I'll show you some of the data. And then we've had recent trials looking at patients who have pulmonary hypertension, where they've got a high blood pressure in the right side of their heart, secondary to their lung disease. When you give them certain medications to do that, there's an improvement. So now, 20 years ago, we had nothing. And now if you look back 20 years later, this is our treatment algorithm. So is there first-line therapy available? We look at the exact cause, and yes. And if not, what should we consider? So again, this has now much better evidence and much better treatment outcomes. So very briefly, just so we can understand some of the newer trials in the last year, I'm going to show you some of the landmark trials over the last 10 years, because these are the ones that dictate the current standard of care. So if we can understand why these are beneficial and why these led to treatment being approved, then when I show you some of the new trials, we'll have a little reason of what is and is not successful. So one of the trials was pirfenidone, which was given in just over 550 patients, and patients were randomized, which means that they were randomly chosen to either get the drug or a placebo, which is a dummy drug. And they were followed for a year, and the primary endpoint was the change in their lung capacity, their FVC, or whether the patient died in that time. And again, coming down to it, this is the figure I want you to look at here in the top right. This is their loss of lung function over time. So we know in IPF, patients will lose lung function over time more rapidly than someone without IPF. But again, the placebo, the non-treated group, is this light color, and they lost lung function more rapidly in that year than the treated group. So the treated group slowed the lung function. And then this is the progression-free survival. This is patients who didn't progress or didn't pass away from their disease compared to placebo. Again, there was an improvement in progression-free survival. And this led to the first, knowledge that this drug is effective in IPF. And, it's not without its side effects, and a lot of the patients on this call will know there's a significant side effect profile. In the trials, about 36% of patients had nausea, and about 12% had vomiting, decreased weight loss. And this has remained true in real world data. Now, just to look at the other drug that came out in the same year, we looked at nintedanib. This is in about 1,000 patients. This is a small molecule, and we have a better understanding of how this works because of the biology of it. Pirfenidone, we don't really know why it works in this condition, but we understand hypothetically why nintedanib works for some of these, going back to what I talked about, understanding that biology, understanding these cells like fibroblasts are important, that remodeling or new blood vessel formation is important. So this targets a number of those pathways. And again, this was done in 2 different studies combined together, this Impulsus 1 and 2, but essentially the data looks similar. So if you focus again on the top, because the bottom is identical, the dark blue are the patients on treatment, and the light gray are those who are on placebo. And again, over a year, they looked at lung function decline, and you can see here it was much more gradual in the treated group than the non-treated group. And similarly, this is the time to first exacerbation requiring hospital admission or significant treatment. The time to exacerbation was different in the 2 groups. But again, they're not, drugs that are necessarily easy to take. There are significant side effects. And again, diarrhea, nausea, and gastrointestinal upset were common symptoms in these trials and have remained so in real world treatment. But this has led to, us having recommendations and approval both from the FDA, the European Medicines Agency. These are approved therapies worldwide now, that both therapies are approved for treatment in IPF. And so if a patient presents to my clinic and has IPF, we would start on this drug unless there was a contraindication or they couldn't tolerate it. Again, it slows lung function decline, but the common side effects are these gastrointestinal upset. But then it raised the question that if we treat IPF with these drugs, what about these other progressive fibrosing conditions that similarly behave or have honeycombing or we know progress? And, so should we use them in progressive fibrosing ILD? And again, I'm not going to show you lots of the detail, but I wanted to kind of come to it. One of these trials was called InBuild. This was published just over 5 years ago now. And they looked at patients with progressive fibrosis of all types. They didn't necessarily they had no IPF, they had other causes. They had connective tissue disease, they had sarcoidosis, they had rheumatoid-associated lung disease, and they had a pattern. So again, at about 60% of them had honeycombing on their CT. You can see it here. And the results were overwhelmingly positive again. The patients treated with nintedanib who had evidence of progressive fibrosis behaving similar to IPF, but didn't have IPF, they did better. Their lung function decline was much slower on treatment than on the placebo group. So again, this led to now we use this as standard treatment. We use nintedanib, and that's approved for patients who have progressive fibrosis, which means they're losing lung function at a certain rate, they have honeycombing on their CT, or they're changing their symptoms rapidly. So we have available treatments for patients. However, the unifying factor of all these studies is the lung function still declined, and this was still a progressive disease. So we don't think we have the perfect answer. You know, patients still have symptoms, and on top of that, their lung function continues to decline, even despite the fact that this is slower. So that's led to a lot of studies ongoing. And I wanted to kind of focus, you know, to show you what's new, what's happened in the last 1 year or so with new studies, because there's a lot of movement in this area, and there's going to be a lot of exciting news in the next few months. So the good news, let's start with the good news, because clinical trials don't always work out. Some of them don't have the effect that we show, like that slide I showed earlier with lots of those circles. Most of those trials, almost the vast majority of those trials, didn't have a positive effect and didn't lead to any new treatment. So I'll talk about one that's ongoing. This is what's called an LPA2 antagonist. This is being run by Bristol Myers Squibb is the company. And this is a tablet, and they're looking at it in both IPF and in progressive fibrosing ILD. And you can be on antifibrotics. So this study is currently recruiting. This is the initial study. This is the first pilot study where they looked at 240 patients, and they randomized them to either get placebo or the drug at 2 different doses. And then they followed them up, okay? And this was this is a pilot study. This is a phase 2 study trying to see, is this effective before you run a much larger study? And you can see it here. This is the IPF patients on the left and the PPF patients on the right. And you can see here, the lung function decline was slower in the IPF and PPF cohorts that got treatment compared to placebo. And again, this is the different doses in blue. So again, the higher dose patients did better and had less lung function decline over that time. So again, this led to this now being designed for a bigger trial. This trial is called a LOFT IPF and LOFT PPF. This has just opened in Ireland. We're a site in St. Vincent's. This is recruiting internationally at the moment in both cohorts, and we plan to recruit hopefully our first patient in the next couple of weeks. But again, what it is you know now it's going to be randomized to the 60 milligram dose, which was the higher dose back here, this one that did well, or 120 milligrams, even twice that, to see is that even more effective. And patients will either get a placebo or one of these 2 doses, and they will be randomized to this, looking at their lung function decline over time. And the important factor is they can remain on their current antifibrotic, nintedanib or pirfenidone. They do not discontinue that. And we think, so the IPF study we know is recruiting very quickly, and we expect data next year. And the PPF study, probably a year to 18 months thereafter. So this is exciting. This looks positive on the early studies, and we have to see does it work out. What about other studies? This is one from a couple of years ago by a different company, and this is looking at what's called a phosphodiesterase inhibitor. And they, again, phosphodiesterase inhibitors, they're involved in inflammation, and they have both anti-inflammatory and anti-fibrotic effects. So the idea is that maybe this drug will be effective in IPF. And again, this is this product, you know, it now has a new name called nerandomilast, but at the time when it was published a few years ago, we had this coded number. And you can see here, this was the change in lung function over a 12-week period. This is the early study to look to see is it feasible. So this is the loss of lung volume. You can see here the placebo group in 50 patients, they had a significant decline, and there was almost no loss of lung function demonstrated by this red line in the treated group over a 12-week period. So this led to a larger study. This led to what's called the Fibroneer study. This is Fibroneer IPF, Fibroneer ILD. So again, looked at it in IPF patients and in PPF patients. And they have, this is finished recruiting, and they have had significant recruitment in both Fibroneer IPF and Fibroneer PPF, and there's been patients in Ireland recruited to this study. Now, the trial results will be released at the American Thoracic Society next month, but they did some headlines, and both of these trials have met their endpoint, which would tell us, till we see the data, that both of them were successful. Both of them showed that they could slow lung function decline over that time, which is really encouraging. And this looks like we now will have a new drug, nerandomilast, which once it gets approval, if this is true, to treat IPF, which is really encouraging, and potentially with PPF as well. So just briefly, with a couple of minutes, I know I'm running a little bit over, a little bit of, not all trials work out. So what about the not so good news? Here's another study called Starscape. And, this was, again, a large study. They recruited over 600 patients, which is a huge number in IPF. And what happened is it had no effect. This is called Zimpatraxin, and it didn't work, okay? They published this last year, which is important to publish negative studies, that not all things work, okay? And you can see here, there was no change in lung function decline. So this was, it's important, and there is no difference. So I'm not going to dwell on this, but it's important to publish these data so we can learn from this and also understand what did or didn't work, so people don't repeat these studies. Similarly, this is a study run by a company called Fibrogen. This is looking at pamrevlumab, which is, again, an inhibitor of a connective tissue growth factor. This was their early study published several years ago, and the green is the treatment group. It looked really encouraging. This is over 48 weeks. It looked like it was going to slow lung function decline. However, there was a large study, 370 patients, and they were looking at over 48 weeks with an injection. This is an injection to be given. And then this was it. There was no change. So in the larger study, it didn't work out. Okay. So, and then similarly, there's another study called Bexategras. This is Integris. This one looked really encouraging at 12 weeks. Again, the drug was better at 12 weeks. Okay. And it led to this study called Beacon IPF. And Beacon IPF has just closed. They pulled it. They stopped running this study because, again, once you do these 12-week studies, they don't all work out. We don't know why, but we know that they didn't meet their endpoint. So, and then I just finished with 2 slides about treating symptoms. So what also is really encouraging, not all studies being done at the moment are about treatment and preventing lung function decline. There's a couple of really good studies recently. One that didn't work out. This one was a study conducted in the UK, Ireland, and a number of other places looking at treating symptoms. They used a drug called mirtazapine, which is an anti-anxiety drug, and they showed no difference. Okay, so there was no difference. But what about treating breathlessness? So we did no improvement in breathlessness. But I want to show this last study. What about treating cough? So we often prescribe patients morphine or morphine sulfate to treat breathlessness. This was a study designed in the UK, and they were randomized, again, to do both arms, to get either morphine or no morphine for cough, and they did both sides of it. So they do a crossover. What that means is that you can do it with less patients, and they did it over time. So again, I'll go straight to the results. The patients with the treatment are in the blue here, and this is their frequency of cough. It reduced on 14 days compared to not treated. And then their quality of life improved and their cough severity improved. So all of this, so morphine works really, really well for cough in patients with IPF. And this is a positive study published at the end of last year to say that simple treatments that we already use, for one thing, we can actually use to improve cough. And there was no serious side effects to this. So that was really encouraging. So in conclusion, we've come a really long way with meaningful therapies. We are building more evidence, but some things don't work out, and that's really important to understand. And trials, even if you're recruited, that doesn't mean it's going to work out. Looks like we're going to have a third agent available very soon, and we'll find this out with the top-line results published next month, sorry. And trials in these other fibrotic lung diseases are possible, and we should continue to do other studies to look at improving quality of life, reducing symptoms. It's not all about mortality and lung function, because to design those studies, you need huge numbers, and there's potentially other things that we can improve care. So sorry, I've taken just a few more minutes of your time there, Maureen. I'm a little bit over, and I'm happy to take any questions.
That's okay. Thank you so much, Cormac. I really appreciate it. And we are out of time, but just to say, one of the questions that came in that was someone who is asking about, they think that they might, they have a certain type of pulmonary fibrosis, and they'd like to know if they're eligible for a specific trial. Would you recommend the best thing that people do is to do probably 2 things? One, if you go to clinicaltrials.gov and you look under lung fibrosis there for Ireland, you can see the trials that are currently recruiting. But the second thing, would it not be to talk to your specialist?
Yeah, I think, certainly look at it yourself, because it'll give you a good idea. But some of the technical terms that are used on clinicaltrials.gov, you may not know that information yourself reading it, even if you're very well informed. So I think once you see this study or you're interested, I think talk to your own ILD specialist, because they'll be able to look at those inclusion criteria or look it up themselves and be very clear with, whether or not you would be eligible, because different types of ILD are excluded for safety reasons, for unclear whether it's going to be effective, or because the way the study has been designed to be as effective to try and prove that it works. So that, it's really important. So some people get excluded even though they feel they may, fit perfectly with everything. But if you have one exclusion criteria, the way these studies are designed is to be really strict so that these drugs get approved, because it's really hard to get drugs approved for any condition, especially rare conditions, where if you had 1 or 2 patients that didn't fit it and it changed the outcome, that might set back a huge amount of resources that have been put in to try and prove its effectiveness. Not that you're trying to treat patients, it's the opposite. It's trying to be beneficial,
And kind of the other end of that, then, just really, really quick, 30 seconds if you could. When a drug, you mentioned there's going to be an announcement coming out here this year with a promising new therapy. How long does it take from the time that announcement comes for the drug to be available for patients?
That's a really good question. So what happens usually in conjunction, so as these companies, especially an industry partner who's doing a large trial like this, they are likely already in discussions with things like the FDA and EMA to get approval. So getting approval by the FDA or EMA is one thing, but then it's getting reimbursement, and that depends on each country. For example, Ireland would look at a reimbursement for when we got pirfenidone and nintedanib. The reimbursement means we as physicians can then prescribe it and the patient will get reimbursed or it'll be paid for. So usually what will happen is, if this is successful, we think this trial is going to be a big landmark one presented in May, and likely that will lead to fairly rapid FDA approval by the end of the year, maybe even before that, and EMA as well. But then the reimbursement might be sometime 6 to 8 months later if it's quick. Sometimes it takes longer. IPF is rare, but it's not so ultra rare that it won't take that long to be reimbursed. So I do imagine if this trial is what we expect and gets approval from the agencies, we potentially would have this treatment to hand next year, will be my hope.
Okay, 2026 is the optimistic picture, maybe later.
I think that's an optimistic, realistic. It wouldn't be this year, and hopefully next year. We're expecting that, from what we've heard, without breaking any confidentiality, this is meant to be a very, very, encouraging study in every way,
Wonderful. Well, with that, we will leave it on the positive note. Cormac, thank you so much for your time. Really appreciate it. Absolutely fascinating presentation.
Sorry, I kept you waiting. I got waylaid for, I won't bore everyone with the details, but I apologize for being 15 minutes late.
No trouble at all. Thank you very much. Next, then, what I would like to do is I would like to introduce our next speaker. Our next speaker is going to be Nazia. And Nazia, I'm so sorry, but I'm going to butcher your last name. You can help us with that if you could.
That's absolutely fine. It's Nazia Chaudhuri.
Chaudhuri, thank you very much. Nazia is a respiratory consultant with a special interest in ILD. She's the senior clinical lecturer at Ulster University. I've heard her speak many times before, and she is absolutely fascinating. So thank you so much, Nazia, and over to you.
Thank you. Thank you so much, Maureen, for the introduction. And thank you to the Irish Lung Fibrosis Association for the invite. So Professor McCarthy has given a nice introduction on the research studies and some of the results. So I'm going to be talking to you in the next 20 minutes about the research pathway. So really just highlighting why it's so important for you all to still be involved in research studies, and talk a little bit about care pathways and the importance of the MDT. I've only got 20 minutes, so I am really just going to touch the surface on these topics as well. So what I thought I would do is just bring us all to the same page and just talk about what is pulmonary fibrosis, just very briefly, or what we sometimes refer to in clinics, and you'll hear us talk about interstitial lung diseases. And then I was going to talk about research and clinical trials and the pathway, as well as then the care pathway and the importance of the MDT. So this is just going to be revision for you all. I'm sure you know, as patients and carers, you know more about your lung disease than I do, really. But in your clinics, you'll hear us use the same different terms for the same things, really. So you'll hear us throw around interstitial lung disease or pulmonary fibrosis. And when we're talking about these things, we are talking about a number of different diagnoses. So it is what we call an umbrella term for over 100 different diagnoses, the commonest being idiopathic pulmonary fibrosis. Idiopathic means unknown cause. Pulmonary is a medical term for lung, and then fibrosis meaning scarring. And how I try and explain it to patients in my clinic, and you'll hear it from explained differently from different consultants, I try and say it's a bit like having a graze on the knee. When you graze your knee, the first thing you notice is it goes pink and weepy, and that's what we mean by inflammation. The lungs are pink and weepy due to any particular cause. It might be something you've breathed in, pollution, etc., smoking. Eventually, that grazed knee forms a scab, and those scabs are hard, and the skin heals really well. Eventually, that scab falls off and the skin heals. But for some reason in the lung, that hard skin, that hard scab forms, and it doesn't heal properly. And that's what we mean by scarring. And that scarred lung can't expand as well as it should do. And so you can't take in all that oxygen, and your lungs really feel like you can't take that deep breath, and they shrink in effect with scarring. So that's what we mean by pulmonary fibrosis. And then from medical term, we have this big algorithm with all the different conditions. But really, from your perspective, just need to be alert that when we talk about idiopathic, we mean IPF, but there are other idiopathic lung conditions, scarring conditions, but that wholly means unknown cause. And then there are known causes. And the things you might have heard of, conditions like pigeon fancy's lung or farmer's lungs, we are politically correct now, we can't say that. And we call that hypersensitivity pneumonitis, or there may be drugs that cause lung fibrosis, or there may be underlying connective tissue diseases like rheumatoid arthritis and scleroderma and lupus as well. So this is what we mean by lung fibrosis or interstitial lung disease. So really a large group of conditions that also includes sarcoidosis as well and smoking-related fibrosis as well. And the reason we worry about these conditions, and you will know more about this, is that unfortunately scarring, we say on the whole, is irreversible, and particularly for IPF, it is invariably progressive, and for other non-idiopathic pulmonary fibrosis, lung fibroses, a certain proportion will progress, leading to breathlessness, then anxiety, low mood, fatigue, cough, that are often very difficult to treat. And so research is really important, because really what we want to find is a cure for pulmonary fibrosis, and we don't have that cure. Currently, the treatments we have, you've heard from one of your patient peers today, can have lots of side effects. Usually 20 to 25% of people will have to stop the drug because of side effects. So we really need better drugs. We need new treatments that have less side effects, and in effect, new treatments that either cure the disease or reverse fibrosis. And the drugs we have at the moment just slow it down. And really, fibrosis is really complex. So we really need to understand why people get pulmonary fibrosis, how it happens, what causes it. You know, we call them idiopathic, but really they're not. We know that if you've got IPF, you're more likely to be male, you're more likely to be a smoker, you're more likely to work in dirty kind of occupations with wood dust, etc. So they must have a cause. You're more likely to have a family history. So we need to know what makes it better, what makes it worse, and why one person gets pulmonary fibrosis and another doesn't. I mentioned pigeon fancier's lung. Not all people that have pigeons or birds get pulmonary fibrosis, only a small proportion do. But why will one person get it and another not? We also need to diagnose it early. So we need a test that we can diagnose pulmonary fibrosis earlier, because often by the time you come to your GP with symptoms, you've lost a lot of lung function. So lots of unanswered questions. So we need to do clinical trials to find new treatments, to test that they're safe, and to test that they actually work. And you'll have heard from Professor McCarthy about the clinical trials that have been positive and coming through, and those, unfortunately, that have been negative. But really, we need to find something that slows the disease down, makes you feel better, because none of the treatments at the moment do, and cure it. And so I wanted to just, one of the questions did ask, how long does it take? And I just wanted to highlight, to do a clinical trial, it takes decades. And it starts off with a very clever scientist in a lab who understands the complexities of what's happening to your cells in your body, what pathways are involved, and does lots of studies in the lab and unfortunately on animals for many, many years before they find potential targets and potential drugs. And that can be almost a decade of people studying things in the lab before they actually enter the human. And when they enter human studies, there are lots of phases, and we call them phase 1 to 4. And I just wanted to highlight that you can see that in these phases, the number of participants increases. So initially very small numbers, and then we have maybe hundreds and thousands of patients in the later phase studies. And the earlier phase studies are principally looking at safety, making sure a drug is safe to begin with. And then the later phases are looking at safety and making sure it works. And this pipeline or this pathway can take up to 10 to 15 years. So you can imagine that's why it's taken so long to only have 2 antifibrotics that are licensed for pulmonary fibrosis at the moment, because they have been studied for about 2 decades, 20 years. And so that's why it takes so long, and it's very frustrating before we get new drugs. And really, this pipeline is really costly as well. It's very expensive. So there's loads of challenges. They're expensive. They need investment. So pharma companies are always looking for investors. And a lot of the drugs fall out of the phase studies because they show some safety issue or safety signal. So whilst there may be thousands of drugs in the labs that are potentials, only maybe a handful ever get to the later phase studies, and only very small proportion actually get licensed. So we've had loads and loads of studies in pulmonary fibrosis with lots of drugs. A lot of them, unfortunately, have been negative recently, which have been very disappointing. But they're not, some of them haven't really been truly negative. And I suspect it might just be the way we're doing the trials. And so I suppose the reason I'm kind of highlighting this to you is just to highlight that we really do need you. We need you as patients to be involved in these clinical trials, because without you, we can't do them. We'll never find a cure. We'll never find a better treatment without you being involved in clinical trials. So if your clinician asks you to be involved in clinical trials, do listen to them, read the leaflets and consider it. It's usually in addition to the normal treatment that you are already on, in additional to licensed treatments. You are, unfortunately, being the test person, with regards to safety. But if it is a positive trial, so for example, Professor Cormac mentioned the positive study that's coming out soon, and we'll find out the results. Often, so our patients that are in that study have been given that drug for free until it gets licensed. And it's going to take, maybe a year or 18 months for the approvals to come through with your governments. And yet those patients in the trials are going to be on that treatment for free until those approvals happen. So you do have some benefits, and I appreciate there are some negatives. You need to come to hospital, have lots of tests. You may get side effects, but on the whole, most patients that get involved in clinical studies have a positive experience to do get involved. And so the next thing I'm going to talk about in the next 5 to 10 minutes is clinical pathways. And when we're talking about a clinical pathway, we really are just talking about your patient journey. And we know that each and every one of you has had a different journey to get to your diagnosis and to get to your treatment. Some of you have had really long journeys. Some of you have had a long time and maybe even misdiagnosis. We know a lot of patients with pulmonary fibrosis are misdiagnosed with COPD or heart failure before they get a diagnosis of pulmonary fibrosis. And it can take many years. And you don't have time to wait. You know, we need to get you on treatment early so that we can make an impact as soon as possible. So when we are talking about developing clinical pathways, what we are talking about is describing a patient journey that is optimal. So what is the best patient journey so that you can get a diagnosis as quickly as possible, so that you can get treatment as quickly as possible. And so that everybody, no matter where you are in the world or where you are in the island, everybody will get the same care. So it helps us as clinicians. Once we have a clinical pathway, it tells us exactly what we should do and when we should do it, so that you as patients get the best quality of care. So it helps to enhance quality of care. It improves your outcomes, make sure you're on treatment quicker, promotes safety. It improves your satisfaction, and it makes sure that we're not, we're using our resources optimally. Because I'm sure you've come to my specialist clinic maybe 2 years down the line because it's been that long to get to me. And I have to repeat the scan again when you had it already 2 years ago. Now, if that pathway was ideal and I saw you within a month, then there's no reason for me to repeat the scan, and I wouldn't be using more money and resource. So it really does optimally utilize the resources, and it makes sure we're treating you with the best evidence. And so it allows us to set goals and using evidence to set and what your expectations are. It helps us to communicate with you and our multidisciplinary team, and that's why MDTs are crucial. It helps us coordinate care, and then it helps us monitor. So we can then see when we deviate from these pathways and say, well, why are we not seeing our patients in a timely manner? Go to our managers. We need more resource. We need more nurses. You know, why are our outcomes different to another region? How do we improve our care? So it is really important to have these clear pathways. And the evidence is out there. So I'm just going to show you some examples. So NICE, National Institute of Health and Clinical Excellence in the United Kingdom, and it tends to be adopted worldwide as well, have got quality standards for IPF. So everybody with IPF should have a multidisciplinary team diagnosis. Everybody should have a specialist nurse available to them. They should be assessed for ambulatory oxygen. They should have pulmonary rehab accessibility, and you should have accessibility to palliative care. And so we have this evidence, and this should be incorporated into the pathways. And it helps us then, if you're not getting this, it helps us to have these conversations with our local trusts saying, why are we not delivering what the guidelines and evidence tells us? And there's loads of technology appraisals about pirfenidone and nintedanib, principally in idiopathic pulmonary fibrosis, but also now in progressive non-IPF pulmonary fibrosis diseases. And then just to show you, as a clinician, I have no excuse of not treating you properly because we've got loads of guidelines. And so these guidelines are what develop our pathways. So I wanted to just very briefly give you the Northern Ireland example. And I know that I'm part of the Irish Thoracic Society, and we have an interstitial lung disease subgroup. And I know that the Republic of Ireland have also developed a care pathway in conjunction with ILFA, and they are in negotiation with the government to try and improve the funding, because we have a similar care pathway in the Republic describing what the patient journey should be to make sure everybody gets equitable care. It helps me in Northern Ireland support our trusts to implement these strategies and to collaborate and deliver high quality care. And so just to give you the example in Northern Ireland, is that we have our two-tiered system where we talk about tier 1 being primary care, and we talk about tier 2 being the hospital trust, and we highlight that it needs to be a multidisciplinary team approach. We need to have radiology support, we need to have pharmacist support, we need to have specialist nurse support, physiotherapists, psychologists. There's a lot of us, clinical trial support as well. And we basically have just described the pathway from start to finish. And for this clinical pathway, we are now in the process. We've met about 6 or 7 times as an ILD group, including primary care, and we're putting metrics into this pathway. We're saying, okay, from seeing a GP, when you go to a GP, as soon as we're raising the awareness with GPs through education, saying if you've got crackles, it's probably IPF, refer them early. So we're trying to shorten that pathway. And then we're defining how long it should take for you to see us. And ideally, you should be seeing us within 6 to 8 weeks. You should have all your tests within 6 to 8 weeks. And then you should be starting treatments within 10 to 12 weeks. So we are at the moment defining these timelines so that we can then have these discussions with our trust to say, we're not meeting our standards. Look, it's taken us 6 months to see a new patient when the pathway says we should be seeing them within 6 to 8 weeks. And this is because we don't have enough nurses, we don't have enough doctors, we need to invest. And then we can start putting business cases to try and invest. And so that's the idea of these pathways. And you'll see that it goes from primary care to what we call secondary care, which is to your hospitals, having MTT discussions, tells you what tests to have, getting a diagnosis. But the key themes at the bottom underneath this is that throughout, no matter where you are, you also need supportive care. So and this needs to be close to home. So you need your pulmonary rehab and your oxygen and your supportive care, ideally in primary care with your primary care physicians. You need to be thinking about lung transplant. We need to be thinking about research throughout all this. And so it truly is a multidisciplinary team approach with the patient at the centre, with the patient at the heart of this pathway. And certainly with the Northern Ireland pathway, we've had our patient support group integral in helping us define this pathway and these metrics. And the overall aim of these clinical pathways is to improve care and ensure it's equal no matter where you are, whether you're in Sligo, Galway or Dublin, you will get the best possible care and treatment for your interstitial lung disease. And no matter who you see from a physician perspective. And so this is similar to the pathway that's been developed in England. England's is slightly different because they have specialist centres, but it has the same theme. And actually, I shared our pathway with the Republic of Ireland ILD working group. And so their pathway is very similar. It's not rocket science. And so there is an ILD pathway, and you should be asking, I would be strongly encouraging you as patient and carers to write to your MPs to tell them, why haven't you adopted the ILD pathway? We need timely treatment. We need access to clinical trials. This is a progressive condition. And the only way actually the MPs listen to us and the MLAs listen to us is yourselves, patients. We are also doing and advocating, but actually we need your voice to be heard too. And ILFA are doing that on your behalf. But as individuals, please also speak to your MPs to try and raise awareness of this pathway that exists, but is currently not adopted because there's no resource. So please do keep lobbying them. So thank you for your time.
Quick question. Do you think that any of the new drugs that are coming out might entirely replace the existing drugs for the existing treatments?
So we're all in the unknown at the moment because they're keeping very quiet. And I think they're waiting for the American Thoracic Society conference, which is in May. So all we know is that they are positive studies, but we don't know what the actual outcome is. So approving a drug, well, it really will depend on whether it looks better than the existing drugs or not. And then also costs. So our governments and NICE will have to do a cost-effective analysis. So I'm not hearing that they're going to replace the current drugs. that I'm not getting that message, but I can't answer that conclusively until after May when we see the actual data. But NICE from an England UK perspective will have to do a cost-effective analysis and then decide how the new treatments are going to fit in. I don't think we'll completely do away with pirfenidone and nintedanib unless we get drugs that stabilize lung function or reverse it. Then obviously they would be better and they would become first line, or they have absolute, even if this next drug does similar things to pirfenidone and nintedanib but are better tolerated, then as clinicians I'd want to have that as first choice. So it really depends on lots of different things, and we at the moment are in the unknown.
Wonderful. Thank you very much. Apologies for the audio. Next, we're going to have Helena, Dilleen from Giddy Studios. Thank you so much, Nazia.
Great, thank you so much, Maureen, and wonderful to be here with everybody. Absolutely wonderful. So it's so inspiring listening to everybody this morning. Frank, thank you so much for giving such insight and giving me such insight as well into this journey, I guess. And I'm here to do some mindfulness with you. So I am going to share just a little bell sound with you initially, and that will intimate that the session has started, but essentially my voice is what's going to guide us through it. You can hear me all right and everything, Maureen, yeah? All good? Thumbs up?
Yes,
Yeah. Yeah, it's still a tiny little bit muffled is the word I would use to describe it, but that sentence did come through a bit clearer, actually.
Okay, thank you.
No problem at all, no problem. So I'm just going to invite everybody to get comfortable where you are. Soften your posture. Notice how you're sitting. Some people may be, even lying down, maybe on a couch or something. Whatever way you are right now, you don't need to change it in any way, but just observe your posture and invite in a sense of ease as best we can, as best we can. I'm going to sound the bell. I'll guide the practice and I'll be no longer than 10 minutes. So just observing the sounds around you now, and I invite you to close your eyes if that's comfortable for you, or if you prefer to keep them open, just find a static spot to hold your gaze. I'm a mindfulness coach, and I just want to reassure that there's no one way to do mindfulness. We lean into this practice and all of our practices with choice, and we follow the parts that feel appropriate for us, and we tweak and tailor make the bits that don't feel so comfortable to suit us better. There's no right way to do this. We can craft our own practices. And I invite you to just bring that sense of ease to how you are in your posture now, letting your shoulders relax, your arms relax, your hands relax. Noticing all the way down to your feet, and actually noticing your feet as they meet the ground beneath you, perhaps, or if you are lying down, you may notice your feet falling left and right, and bringing our attention to our left foot now, just noticing and even labeling, that's my left foot. Noticing every little muscle and fiber in the left foot, maybe even a sensation of some kind. And then bringing our attention across to our right foot. And if I was to invite you to notice every little muscle in the right foot, just observing as best we can. We'll all experience this differently, but just noticing, my right foot. And then scanning from the right foot all the way up the right lower leg and arriving in our right knee. And if it's helpful for you, you might label, right knee. And from the right knee all the way up to where we meet the surface beneath us. You may be on a chair or some kind of surface, and actually noticing where our seat meets the surface beneath us. That sense of connection to the present moment by observing where we meet the surfaces around us. Moving across to the left ankle with the beginner's mind now. My left ankle. And following from the left ankle all the way up the left lower leg into the left knee. And from the left knee all the way up our left thigh, left upper leg, into our left sit bone. Maybe we'd call it our hip, our left hip, and then scanning across the pelvis, arriving into the lower back, and just resting there for a moment, noticing, that's the base of my spine. And inviting in a softness now to our torso, relaxing our abdomen, our diaphragm, relaxing our chest as best we can, noticing our shoulders, letting our left arm fall down from our left shoulder and softening here. Letting go of any tightness or tension that might be anywhere in the left arm. And arriving with the beginner's mind into the left hand now. My left hand. And noticing our hand in whatever way is accessible for us. Noticing the open hand, the softness in the fingers. We may even notice a sensation in the palm of our hand. We may be drawn to noticing our fingers, and maybe even a gentle movement in the left hand might be available to us. Moving the hand gently and slowly, almost like a rhythm that feels calm and accessible to us. And then pausing here and just observing any sensations in the left hand. And moving our focus now to our right shoulder and letting our right arm relax all the way down the right side of the body as best we can. Not overly striving, just meeting ourselves with warm acceptance. And noticing any sensations now as we arrive into our right hand. Noticing the fingers of our right hand and maybe a gentle movement being brought in there as best we can. And then returning to just calm in the right hand. Noticing any sensations in the palm of the right hand. Observing how sensations come and go with every single moment. Our sensations don't stay the same. They're always changing, always morphing. Each sensation has its own quality to be observed. And as we come into the last minutes of our practice now, I'm going to guide us into just noticing all the muscles in our face, scanning from our forehead, our eyes, our cheeks, our mouth, our jaw, even if we can, nearly relaxing our teeth and our tongue. Not striving, just noticing where we can invite in a sense of ease as best we can. A sense of allowing as best we can. Dropping the resistance and bringing our attention now to sound with a beginner's mind, an arrival of sorts, an arrival into this moment, firstly by listening to the anchor of my voice. And then as I go quiet, just noticing the sounds around you in your immediate space firstly. Could be the ticking of a clock, sound from a computer, sound from maybe machines in our space. And just creating a relationship with those sounds of non-judgment where possible, noticing them coming and going, changing with every moment. And then widening our awareness to the sounds further outside our space. Maybe there's music, maybe there's birds, maybe there's traffic. We're not getting caught up in the story. We're not trying to create a narrative around the sounds. We're just noticing them for what they are, changing sounds. And they change with every single moment, just like life. Listening in the quiet just for a moment. And coming back into the body as best we can and accessing that sense of ease, relax and calm by resting every single muscle as best we can. Noticing our hands one more time, even opening and closing them if we can. And then listening to the sound of the bell right through to the end. Handing back over to the team. Wonderful to be with you today, and I'll share lots of different resources with everybody. There's a daily message that we might share on the email called the Daily Drop, and it's a way of people getting a daily mindfulness prompt. But I don't want to take any more time. It was a pleasure to be with you all, and we'll chat again soon in one way, shape, or form. Thank you, Maureen, and everybody.
Helena, that was incredibly relaxing. Thank you very much. Can you hear me okay?
You're perfect. Yeah, like you were earlier.
Oh, okay. I could solve the problem. Thank you so much for that, Helena, for this mindfulness session, as well as for all of the teaching that you do. It's excellent. So thank you.
My pleasure, and thank you for the invite to be part of today. It's a real pleasure to virtually meet everybody, and best of luck with the rest of the session.
Wonderful. Thank you.
Bye.
Okay. So Zita and Sara, have we got you here?
You certainly do. Yeah.
Wonderful. If it's okay, I think we're running just a tiny bit behind schedule. So we're gonna use that last 10-minute mindfulness as our break. And then we're gonna jump straight to you if that's all right.
That's fine. So we just need to start out, okay. Okay, and we are going to just try and do our computer. Continue and then share. And then we gotta go to here and we're gonna go from the start. So can everybody see us and see our presentation?
That is perfect.
Sorry. So firstly, thank you very much to ILFA and to Gemma, Kelly, Maureen for all your support to us. And we very much appreciate that you support our patients hugely. And we hear that back. And it's great for us as well. So I'm Zita and I'm one of the transplant coordinators here in the Mater, and Sara is one of our registered advanced nurse practitioners in the post-transplant area. So between the two of us, we are going to do a very short presentation, giving an idea of, you know, life, say before and on the list and after transplant. So I hope this is of benefit to you all. So firstly, we just wanted to describe there's a process which in very simplified version, it's from referral to coming in here for an assessment, then getting a load of tests done, being placed hopefully onto a list, and then toward the path of transplant, which simplifies what is a very complex journey. So the first way that people are referred is by you yourselves being diagnosed, and then your referring physician filling in a referral form. And I'd say many brilliant physicians around the country and their teams have identified people whom they think that may benefit from being assessed for transplant. So they can access this referral form. It's online. They fill that in. It comes to the Mater, and we have 3 consultant physicians, transplant physicians here, who look at those letters and then say, okay, we're going to bring this person into the outpatients clinic. So the first meeting would be in a clinic, and then the decision is made to go onto a list to come in for a full and comprehensive assessment. And you can see there's about 3 or 4 pages of tests that need to be done when anybody comes in for assessment. And why are we doing the assessment? It's to determine the severity of the lung disease that one has, but also to evaluate how is every other part of the body. Is this person sick enough to need a transplant, but is the rest of the body well enough to carry them through such a major surgery? So that is the purpose of the assessment. So when anybody comes in here for an assessment, myself and my 5 colleagues who are also transplant coordinators here, we're assigned, each one of us are assigned to a patient, and we hopefully then will accompany them on their journey through assessment. They will also then meet all the multidisciplinary team members, and they are many and varied. And each one of them has their own area of expertise, be it the dietitian, be it the psychologist, be it the physio. Every single one of them has something to offer and information to give. So we encourage every patient to, get as much info as they can whilst they're here. Then the hope would be that we will then inform every patient what is involved in this assessment, what happens when their case is discussed, what happens if they were deemed suitable and going on a list, and then what would happen if they were on a list and if they were called. Because we're giving all that information in the hope that if they were deemed suitable, and it was advised by all these great experts that they go on to a list, that they and their families can give informed consent, because transplant isn't for everybody, and not everybody wants to go down that route or treatment path. So that's very important as well to say, that everybody will be cared for by all of these great team members, but the final decision will always lie with the person who's been assessed and their families. When people are, deemed suitable to go onto our list, we then as coordinators would ring them to say their case has been discussed, they've been deemed suitable, and then we would say, are you happy to go onto a list? And we would go through everything again about what to expect if one is on a list. And then, and I think Frank will understand this, we ring once weekly. We want to know how everybody is all the time. So we ring every single week. We ring everybody on our list. We want to know, how are they doing? What is their exercise levels like? Is there any signs of infection? Have they been seen by their own team? Has there been any tests done? When is their next appointment to come back to us? And generally, how are they doing? And how are the family doing? Because we are very cognizant of the arduous pressure that people are under when they're being assessed, when they're on a list, and whilst they're waiting for that phone to go for a potential transplant. And what was clearly described there by Frank, he's had multiple offers and he's been brought in. For some patients, they may not get an offer. For some, they do. For some, they get multiple offers. So what happens on the day or the night of a transplant is kind of summarized here in very small, amount, but it's a lot for every patient and every family to go through. So we are on call and we receive donor offers, and we then discuss all of that information we receive with the surgeons and physicians. Then it's decided whom are the patients we're going to bring in, and multiple patients are usually called. We transfer them, as Frank has described, to the hospital by ambulance. We don't rely on families because it's too stressful for them. So they come in and they're worked up for a possible operation. And again, as Frank alluded to, the transplant either goes ahead or it's cancelled. It may be more suitable for somebody else. And it's a long day, a long night for everybody involved. And we always say it can take time to recover from coming in and from a transplant not going ahead. So that is something that we try and emphasize at the very beginning. And we do appreciate, and having been lucky enough to meet many, many great patients who've come to us and who've come through the whole journey, that patients on the list, they do have high expectations in the transplant, because they can see that it might allow them to imagine a future where they don't have as many limitations, and then that the transplant itself will give them a second chance at living. Totally understand this, idea for them, and we try and support them to maintain that hope as well. We also are, we put a great emphasis on the patients and their families and carers, because transplant is very complex, and Sara will allude to this as well, is that it's very complex and demanding process for the patient and family. So we need to know when they're being assessed that they are happy to participate, kind of stick with all the rules that we are giving them, which can be tough, and also that they'll be able to adhere to treatment. For some patients, they don't want this treatment because they feel that maybe taking a lot of medications afterwards and the side effects, and they may not just want to go through a major surgery, and we have to respect that too. The social contract, which sounds very official, but it is something that our medical social work department here developed, where people have to identify those persons who will be the key support group for them during their time on a list and afterwards, because they will need support, and that is important. Palliative care, and it was slightly referred to there by Nazia in relation to, and by Cormac McCarthy, was that we do need to raise the word palliative care, because it can be a daunting one for patients to hear. Every patient that is referred to us, we know has a very, debilitating lung disease, and it's an end organ disease, which is going to mean that they are going to deteriorate. And we always hope that people will have talked to patients, and I think that Frank described his consultant saying that to him, and that they're talking about planning, life planning. And then also the fact that we have the benefit of palliative care support team here that can offer guidance as to the use of morphine for all of our patients, perhaps that need it on the list. So that we're talking about that, that we're using palliative care for symptom control, for all of our patients on the list, that we're not basically using it just for end-of-life care. Then I think it's a difficult, but we have to always be very honest with our patients who are going on our list and their families. But for some people, they may be on our list and they may deteriorate. And for some patients, that they will then kind of be reevaluated, and it'll be determined that perhaps to do a transplant would actually not be a benefit for them, that the quality 5-year survival might be unacceptably low. And then our teams would have to talk with everybody in the family and the patient to say, look, this is not going to be a benefit to you. And that can be very difficult, because then coming off a list, and that list may have given them hope. And now it's sometimes, for some patients, they appreciate coming off the list because they know that they're not able. But again, it's full discussion, open disclosure, everybody has to be talked to. We also have cases where patients who are on our list require an increase in oxygen therapy. So therefore, they're on so much oxygen that they can't manage to be at home with that amount. And then for some few patients, but they may need to come in and be admitted into the hospital and wait here. And that can be a difficult path, because as if you're at home or anywhere on an active list, we don't know if or when an offer will come that will be a match. And that can be, again, a difficult path. But we try and talk about that again from the beginning, so that people are aware that these are the different pathways that can evolve. So, as mentioned, it is a very complex process. And for some patients, they come in, they have an assessment done in 7 to 10 days. For other patients, tests will bring up different results that need to be further investigated. And it can be a long and protracted course. So when we have anybody in for assessment, everybody's journey is different. And everybody's family dynamic is different. So we try and help and adapt and guide for everybody on their individual needs. And it is really thanks to the key people who are involved in this journey, and that is the donor and their family, the recipient patients and all their families and carers, the referring teams who send these referrals in, and of course our huge multidisciplinary team here who help to guide toward that life post-transplant. So I'm going to hand over to Sara, who is going to continue this journey. So I'm going to hand over.
Great.
Thank you, Sara.
Lovely. Thank you so much. Thanks, Zita, for that. Thank you, Maureen, Kelly and Gemma, for giving me the opportunity to speak today and share my work in looking after patients after lung transplant. As you say, my name is Sara Winward. I'm a nurse practitioner here in the Mater Hospital. I've had the good fortune and the privilege to work in the transplant program from the very beginning. And we are celebrating this May, our 20th anniversary of the lung transplant program here in Ireland. So it's great excitement. I think I probably have the best job ever, because I get to look after patients and continue their journey after transplant and meet all the wonderful patients and their families. So it is a great privilege and good fortune that I speak with you today. So we know that lung transplantation is truly life-saving, and listening to patient stories, I think it's the simple things that really make a difference after transplant. It's the being able to get up, get dressed, have a shower, walk up and down the stairs, go to the shops, visit family and friends. And those are the really simple but so important things that that mean so much. Perhaps, hopefully not needing oxygen, but unfortunately sometimes patients need oxygen after transplant. But it's having that freedom. It is a tough journey. And I think when I'm talking to patients, even before transplant, you know, it is a lifelong commitment to the transplant program, and for both family and for patients as well. And everyone needs to go in with their eyes wide open. It is tough, and you need to be resilient because there can be unexpected complications. And I'll just talk a little bit about that in the next couple of slides. In this photograph, you can see it myself, but Fiona, Lee, Linda, who looks after patients in the remote monitoring program, and Catherine, who's CF specialist nurse, and Susan Talbot-Towell, lung transplant nurse with a specialist interest in cystic fibrosis. So we are the five nurses of working amongst amazing MDT, looking after patients when they go home. So there is frequent follow-up needed after transplant because of all to prevent all and address any potential complications. So the clinic is operational Monday to Friday. I have my own clinic on a Monday. Patients are asked to come in weekly for 4 to 6 weeks, fortnightly for up to 12 weeks, monthly and 2 monthly, and so forth. There is a need to come to the transplant clinic at least every 3 to 6 months, perhaps more, lifelong. So it is a big ask. Patients come from all over Ireland, from Kerry, Galway, wherever, Donegal, and I think that it does take a bit of you know, organising, and I think that's what Zita was alluding to in terms of the contract, that the patients and their families know that this is going to be something that's patients are going to need follow up here in the Mater Hospital lifelong. So when patients have transplants, they require a lot of blood tests, either with us or the GPs, X-rays, pulmonary function tests. You have radiology imaging. We have 14 dedicated transplant beds here that are used for pre-post transplant. Sometimes we can patients can be admitted straight to these beds if that's what was needed, rather than going through the emergency department. But unfortunately, sometimes that's not quite possible. We rely on shared care with other referring physicians around the country, and also GPs to organise perhaps tests and investigations that are needed. And I think the unsung heroes really are the support people in patients' lives, the family and the caregivers that provide such an amazing support and really are valued. We spend a lot of time talking about medication. This is the cornerstone to the success of the transplant. Patients are required to take 3 immunosuppression agents, medications lifelong, and without those, the lung will fail. So a lot of time is spent educating on with a transplant pharmacist and the nurses on making sure that patients are aware of what medications they're taking, when they should be taken, and to make sure they understand the importance of taking these medications. The immunosuppression is time specific and time critical, so it has to be taken at specific times, and it's also brand specific. And there are many drug interactions. So we'd ask that patients get a medication box, and they put all the medications in so they can be seen clearly, and sit down when they're due to take them, turn off the phone, turn off any distractions, and sit with their medication diary and go through all the medications one by one. Even if they've been transplanted 1 year, 10 years, whatever, 5 years, the same principles apply, because you can never be too complacent about taking medications. We'd advise after transplant that patients wouldn't use blister pack, but I do know that it is a great resource, but patients need to know their tablets. And sometimes they are stopped and started, and it's quite challenging if you have a blister pack to sort of change all that, and to make sure that medications don't run out. With medications come the golden rules, and we'd ask patients not to start or stop any medications unless we say that's okay. And as I say, to use a diary is so important. I actually borrowed this slide from Patricia Gang, who's the transplant pharmacist, and I think it sort of speaks 1,000 words. So the interactions are at the top left, my left, is the grapefruit. So the immunosuppression program for cyclosporin, there's a drug-drug interaction with grapefruit. So that's a no. No herbal remedies, no pick-me-ups, no herbal teas. Again, these cause interactions with immunosuppression and can cause toxic levels and then have a knock-on effect and cause kidney problems and then all sorts of other complications, unnecessary admissions. The two ladies talking, it doesn't mean don't speak to your neighbours, but what it actually means is take the advice from the experts who are in the hospital, rather than for your friends or family or people who are close to you, although they mean very well. It's best to speak to us here in the transplant team. Unfortunately, with taking immunosuppression, you're more vulnerable to infections, and sometimes you don't always get the same immune response as you would pre-transplant. What I mean to say is you may not also always mount a temperature, but you might feel tired or sick or unwell, and it's not okay to stay in bed and to say, oh, I'll ride it through. I'll ring the team on whenever, a couple of days, because things can only get worse, and the longer you leave the problems, the infection will just cause a more serious effect on the lungs. So it's really super important to ring us whenever you feel that something's different and something's not quite the same. We're always advised to give flu and to get the flu and COVID vaccines, and the seasonal COVID vaccine, the spring vaccine, is actually for COVID, I think, is available now. So this, I'm not a dietitian, but I think the reason I put this slide up, because there are lifestyle changes after transplant, including requiring to take a clean diet. And what I mean by that is no, everything, all the meats has to be well cooked, no sort of rare steaks and so forth. And shellfish has to be thoroughly cooked. Seafood is used with caution, fruit and vegetables washed and peeled and so forth, bottled water, and that's really just to prevent any gastrointestinal upset. I borrowed this slide from one of the dietitians who gave a really nice talk, and what she was putting in the emphasis on this food pyramid, which was the healthy food for life, was just enjoying food. Food is important. It's part of our enjoyment throughout the day, to prepare food and to eat food, but just be mindful of just to eat for health, and to live your best life includes eating a healthy diet. There is a tendency to put on weight after transplant with the steroids. It would give it an increase in appetite. Patients don't find they're burning off as many calories, not trying to breathe. So this is all good, but suggest that everyone will have a dietetic review after transplant. They will know their ideal weight, their target weight, and trying to keep to that. So it's really important to have a regular meal pattern, to eat fruit and vegetables. Of course, we all know that. The fruit, the 5 to 7 a day portions are illustrated here. Increasing dietary fiber, fruit and vegetables, dairy products. So I think one of the take-home messages I took from the dietitian was, rather than trying to avoid things, was add in the good things, like having a glass of milk with meals, having the yogurt, having the small portions of cheeses, really to give you that nourishment. Try to use whole grain bread, cereals, pastas, rice, and having nuts and seeds as a snack. So that's what I took from that. Exercise is super important, and I was talking to a lady yesterday. I had to ring her about a change of medications. She said, Sarah, I can't talk to you now. I'm in the middle of ILFA exercise class, and that was only amazing, because I think she really struggled, and she said that herself, with getting back on track. And she was tired after having the transplant, and she really just was, it's just difficult. So get on the ILFA classes was just brilliant. Delighted for her. So this is, I was part of Team Ireland that went to Lisbon for part of the Transplant Games. That was last year. It was brilliant, amazing week, where patients participated in all sorts of sports like darts, running, cycling, swimming. And it was so brilliant to see so many people just so enthusiastic about life and enjoying life and getting out there. in terms of exercise after transplant, the physiotherapist will give each patient a structured exercise program tailored to them. And this is so they can continue on the exercise at home. We're getting an exercise bike, which would be ideal, a indoor bike, and doing strengthening and conditioning exercises very similar to the ILFA classes. So in the gentleman with their medals, the gentleman in the center is a patient with cystic fibrosis, is now 10 years transplanted. And he is such a breath of fresh air when he had such a good time in Lisbon. It was brilliant. And Robert McCutcheon's the chair of the Transplant Association group, and the gentleman on the left is a heart transplant recipient. So it was really fantastic. There's a lot of information that's needed to be given after transplant, and we organise a masterclass for dietitian, for physio, for pharmacy, and social worker and psychologist to come together to give short presentations, a bit like this, to patients and their families, to really kind of go through all the information again, just so that it's and just to make sure that everyone is on track, I guess, but also a really nice opportunity for patients and their families, and to talk with one another. Peer-to-peer support is so important. So that was it's a really excellent day as well. We produce these little cards that for patients and families put in their wallets, because with our contact numbers for sure on one side, and then just the medications that patients can never have. Patients will see multiple different specialties and GPs and so forth, and without unbeknownst to themselves, they may prescribe something that's not suitable and will cause a drug-drug interaction and cause something like kidney failure. And that's true, that has happened. So we give patients these cards so they can show the person who's prescribing for them, I can't have these medications, and also to the local pharmacy as well. So that's been really successful. So I'm just going to finish off by saying I'm one person. I work with the most amazing team, and so fortunate to work in this fantastic team and to look after so many wonderful people. So I'm just saying on behalf of all, thank you so much for having me speak today. Thank you. Thank you, Maureen.
Wonderful. Thank you so much, Sara. Thank you, Zita. And we are well and truly out of time, I'm afraid, but there is one question, if there's any way, and it's a really hard question, if there's any way to answer it quickly, that would be great. If not, totally understandable. But it's a question that 3 people have submitted, and one that I hear every time I talk to patients, and that is age limits on transplants. Is there an age limit?
To be very honest with you, I and Sara have been here since the very beginning. And in the very beginning, there was, fairly strict, age limits. I think as the years progressed since 2005, we've done more patients, and probably the expertise has improved, and more people coming back, surgeons-wise, from foreign places. So in fairness, everybody can come in to be assessed, but when it comes to people who are between the 65 to 70 mark, it is very much, as we said earlier, you're assessing the sickness of one's lungs, but the wellness of every other part of your body. And it is difficult to say a certain specific number, because we have had people who have been, say, 65, perhaps not mobile, perhaps, wheelchair bound. And then we've had people who are maybe 67, 68, who are still running, so it's about, as they say, chronological age and biological age can be very different. So when somebody is 60 and above, being very honest, and this is again what we would always say, is that you need to be very, very fit apart from your lungs when you go beyond the 60 plus age group. And as I will anticipate, even when I'm heading to those years, there may be cardiac issues, that people may have. So that's why I say I cannot give a definitive number, but I would say when you go past the 65 age group, you would need to be extremely fit apart from one's lungs.
Okay, thank you for that. And again, really important to note that it's not the age number, it is the fitness. And if somebody is interested in being considered for a transplant, they would go to their specialist and say, and express that interest, and then the specialist would be able to guide them. Is that what they do?
Yes. And we would say most of the, brilliant referring teams around the country would be aware of the referral process, where there is a referral literally document on the MAT or intranet internet that they can download, they fill out, and basically they send it here to the MAT or hospital, and basically it would then be triaged by our 3 consultants, then a clinic appointment made. And again, it's something that, some of these consultants that know the consultants here, so they can ring them and say, look, we have this person. Again, rather than raise expectations, be honest and say, look, I'm concerned about one area, so should I put through the referral, rather than giving anybody any unnecessary hope that would be dashed. That would be unfair,
Okay, that's really good to know. Zita and Sara, thank you so much for that incredibly informative session. If you could please stop sharing your slides now, and we can move on to our final speaker. Our final speaker we have is Carol Doherty, who is going to talk with us today about oxygen therapy. Carol, over to you.
Thank you very much, Maureen. Thanks to everyone in ILFA for your continued support. I appreciate there was a very comprehensive talk on oxygen therapy a few weeks ago from the companies, so I'll be just careful not to overlap. So I suppose we'll begin with, to gain a recap of today, why is oxygen therapy used in pulmonary fibrosis? And if we start off by looking at healthy lung and alveoli, the alveoli, they're small air sacs, and they're located at the periphery of the lung. And this is where the exchange of oxygen and carbon dioxide between the lungs and the bloodstream takes place. And this process is called gaseous exchange. And these little alveoli, they're specially developed to make gaseous exchange efficient. On average, we have about 450 million of these. So therefore, they provide a large surface area, and they're thin. Their walls are very thin to allow oxygen to easily pass through the walls and into the bloodstream. And they also have a very rich supply of small blood vessels called capillaries, and they're available to pick up the oxygen and deliver it around the body. And in turn, the carbon dioxide, which is a waste product, it is removed from the bloodstream via the lungs, where we breathe it out. However, if we look over to the right then, in pulmonary fibrosis, the alveoli, they become damaged, and the delicate wall surrounding the alveoli, we call it interstitium, it becomes remodeled, whereby the lungs become scarred, stiff, and they've got reduced elasticity. And this then makes it harder for the oxygen to pass into the bloodstream. And as you can see there, the walls are thick, and because they're thick, then the transfer of oxygen takes longer. And this then can lead to what we call hypoxia, which is characterized by reduced oxygen levels in the blood. And when we talk about hypoxia, some of the symptoms that people will experience is increased breathlessness on exertion, a lower endurance during exercise, a change in respiratory rate. And when we talk about a change in respiratory rate, you're breathing harder, deeper, faster. A lot of people have Fitbits, so they might notice that their heart rate is faster as well. Increased working of breathing. This is the use of muscles, so you can actually physically see that that person's working hard. Some people have pulse oximeters, so they will see that their oxygen levels is dropping as well during exertion. Some people will be restless, and they'll be fatigued just due to the activity of working harder to breathe. Severe hypoxia can bring around colour changes to the lips and to the tips of the fingers. It's a bluey tinge. And then mental alertness as well. Some people may notice that, or family members might notice that they're confused, and that's because there's a lack of oxygen going to the brain. So whenever we talk about oxygen therapy or supplementary oxygen, it's extra oxygen that it's prescribed to a patient who's not getting enough oxygen into their blood naturally through normal breathing. And therefore, the goal of oxygen therapy is to maintain a healthy level of oxygen in the blood so that the organs and the tissues can function effectively. And Therefore, oxygen, it is a drug, and it requires a prescription from a healthcare professional that is based on your individual oxygen assessment. And you may see the letters AOT, and this is ambulatory oxygen therapy. And this is supplementary oxygen that is prescribed during exercise or activities when you're up and about. And then we've got LTOP, which is long-term oxygen therapy. And this is prescribed to someone who has proven hypoxemia, which is low levels of oxygen in the blood for a minimum of 15 hours a day. So these are people that need oxygen all the time. So the role of oxygen therapy in pulmonary fibrosis, well, it improves oxygen levels. It improves breathlessness. People feel they can breathe easier. It improves quality of life, and there's less feelings of fatigue. So people feel a wee bit more energized, and therefore they're more active. And very important, it reduces stress on other organs, particularly the heart, because a complication of chronic hypoxia would lead to pulmonary hypertension. So whenever we work with, in relation to oxygen, we work in accordance to best practice guidelines. And in this case, we use the Irish Thoracic Society guidelines for oxygen in the acute setting and for long-term oxygen therapy. And why do we use guidelines? Well, it standardizes care. It provides clarity for us, the clinicians, and it ensures safe care for anyone that requires oxygen therapy. Anyone that is coming in for an oxygen assessment, they will receive a comprehensive respiratory assessment. And if someone has maybe a history of COPD or asthma, we would optimize their treatment. And we would also outrule other causes of breathlessness if they can be resolved. And we also use breathlessness scores, for instance, the Borg, which is 0 to 10, how bad your breathlessness is, and the MRC. And this is just to gauge patients' perception of what they see their oxygen as. So first and foremost, we do the oxygen oximeter, and it's a sensor device which it attaches to the finger or the earlobe, and it monitors the percentage of oxygen saturation hemoglobin, which basically estimates the oxygen level in the blood. And it does provide an accurate reading, provided the circulation is good. However, if someone has poor circulation, maybe they have a tremor, or they're anemic, or they just have cold fingers, or indeed even very dark, thick nail varnish, it can affect the readings. And based on this here, then it will guide us as to what to do. So we have parameters. So for instance, if someone oxygen level was 92 or below, we would then proceed then to do an arterial blood gas. If it is above 92, we would proceed then with a 6-minute walk test. So it guides our practice. So if we were doing a 6-minute walk test, and this is important because whenever someone with pulmonary fibrosis, and indeed us all, whenever you're active and exercising, your body will use up more oxygen. Therefore, in order to assess your oxygen levels on exertion, we would ask you to complete a 6-minute walk. And for this, we would ask you to walk on a corridor at your own pace. And if you need to take a rest during the 6 minutes, you're allowed to do so. And you'll have a pulse oximeter attached to your finger or your ear, and the health professional, whether it's the physiotherapist or a nurse, they'll be monitoring your oxygen level, your heart rate, the distance you've walked in meters, and they'll be observing your breathlessness score as well. Now, if the oxygen level does fall below a parameter, you will be asked to have a rest for 20 minutes. And after this, you'll be asked to walk again, do the 6-minute walk test, where oxygen will be applied, and it'll be titrated to a flow rate that will hopefully achieve an oxygen saturation of above 90%. That'll improve your exercise tolerance and your breathlessness. Overnight pulse oximetries. So sometimes clinicians will give one of the devices to someone to wear when they're in bed at night. And this is to see what your oxygen levels are like whilst you are sleeping, because sometimes people need oxygen at nighttime. And then finally, we've got the arterial blood gas, or the ABG. And this is an invasive test in which a sample of blood is taken from the radial artery in the wrist. And this is the most accurate of tests. And the results of the ABG, it shows us if your body is getting enough oxygen and that you're able to get rid of enough carbon dioxide, which is the waste product when you breathe out. However, if this test does show that your oxygen level is low, and again, we have parameters, the next step would be to assess, well, how much oxygen do you need to bring your oxygen levels up to a safe level? And in that case, we would ask you to wear oxygen for about half an hour, and we repeat the arterial blood gas. And this is just to ensure that you're getting a safe percentage of oxygen prescribed that is based on your current oxygen needs. So if the decision is made that you do need oxygen therapy, as you can see, there's a range of devices and given sets for oxygen. And I'm not going to go through them because that was done a few weeks ago. But the oxygen devices prescribed will depend on your individualized oxygen assessment. We've got, for instance, the conserver, and we've got the portable oxygen concentrators, and they're pulse flow. So they deliver short bursts of oxygen only when the patient inhales through the nasal cannula, so therefore may not be suitable for someone that's a mouth breather. And then we look at how the person's going to carry the oxygen. Are they going to use a bag? Do they need a trolley? Do they need a rollator? So all these things are taken into account. And as Frank said earlier on, he's got 4 concentrators, and that's because that is tailored to his needs at home. So the ordering of oxygen, it's slightly changed in the last year, where oxygen is now prescribed on a hoof oxygen order form. When oxygen is prescribed, the patient signs an information agreement form, and the oxygen company then is responsible for the delivery, the installation, the maintenance of equipment. And the technicians then will provide training on the equipment, and they'll carry out a risk assessment. And there's 2 ways in which the oxygen is ordered. So for people that don't have a medical card, the WHO form is sent directly to the oxygen company, whereby it is delivered into your home. We would advise that patients that don't have a medical card apply for the drugs payment scheme, because under this scheme, all drugs, including oxygen, will equate to €80 per month. And then we've got patients that do have the medical card. So the WHO form will go to HSE stores, where they'll get HSE approval, and that will be then sent to the oxygen company. I would like to note on this, excuse me, on this point, if you have cylinders at home and you maybe are entitled to 8, 16, 24, whatever, it's coming up to the 3rd week of the month, and you might have only 2, 3 cylinders left, please contact your health provider. We can easily increase your cylinder prescription, and if it means that you're out and about enjoying life, we'd rather you do that. Especially coming in now to the brighter evenings, you might find that you want to get out more, the weather's kinder, and as well as that, people who are starting pulmonary rehabilitation classes, they might find that they're going through the cylinders a bit quicker as well. So that there's just a copy of the new WHO form, and just this prescription needs to be renewed on a yearly basis. So your prescription of oxygen at the very least will be reviewed yearly. For us, we see patients every 3 months or every 6 months. If they've got out of hospital with oxygen, it's normally after 2 months we would review them. And that there's just a copy of the oxygen therapy safety advice, and this is provided for the service users. And you can see that there's a few email addresses there in how to apply for the DPS card, and also to register as a priority patient with the ESB if you've got long-term oxygen therapy. So I'm not going to go through the safety aspects because the company went through that a few weeks ago. So just in relation to daily care, it's important to keep the nasal cannula and the masks clean. So the masks can be washed in warm soapy water and rinsed and let to air dry. The nasal cannulas, the prongs can get secretions can build up on that. So again, we do not immerse in water. What we would say is just wipe with a cloth. Because if you were to put it into water, the water can get down into the tubing and can cause chest infections. It's important to observe for signs of tissue damage, particularly around the ears and the nose. And like that, the company does provide padding for the ears if it becomes irritated. Maintain hydration, minimize mouth dryness. Like that, starting off on oxygen, it can be drying out. So only use water-based creams. So stay away from Vaseline, it's got petroleum in it. So we would advocate for aloe vera cream or KY jellies. Very important as well, if you're in hospital, do not take the equipment home. This equipment, it's disposable, it's not meant to be washed, and also it carries the risk of infection control. If you've gone into hospital with an infection and you're not properly able to clean the equipment, you're at risk there of infection. And then changing the nasal cannulas and masks, and the companies will provide you with new masks and cannulas. So just summarising, always follow the safety advice in relation to the use of the equipment, and also follow the advice from your healthcare professional in regards to the use of the oxygen. Never adjust the oxygen unless it's been discussed with your health professional, and therefore never use more or less than prescribed. You've had a comprehensive oxygen assessment, and that is based on your needs. So challenges and considerations. I added this picture. I think this picture illustrates different emotions that, after being told that you may need oxygen therapy, can bring about different feelings. And I suppose I'll start off with the green happy face. For some people, it's a sense of relief that they've been told they need oxygen. It's a sense of reassurance, they feel safe. And it's also maybe a newfound freedom that they can start doing things again that they felt that they couldn't do or enjoy prior to needing the oxygen. However, it must be acknowledged that the impact of needing oxygen therapy for others, it can be profound, as it can be seen as a negative milestone in the disease as it's progressing. And it might be very difficult to adjust to the new lifestyle. You know, there's thoughts then of loss of freedom, the inconvenience that oxygen has. And not only that, but oxygen is visible. People can see your medication. And this can lead to a fear of what other people's perceptions of why you're on the oxygen. And this in turn then can lead to issues of compliance. People may avoid using the oxygen out in public, or they may avoid going out in public at all. And then in turn, this can also lead to increased fear, anxiety, and ultimately social isolation. And then there's also the practical considerations in relation to oxygen. You need to plan trips. It's dealing with flow rates, ordering cylinders, and learning about the new equipment. However, you would be surprised. It's amazing to see people, you know, when you're telling them they've got needing oxygen, and then they come back and how au fait they are with it, and they're, you know, they completely get on board with it. And they realize, I think it's because you quickly realize the benefits that it brings in improving your breathlessness and fatigue and your overall quality of life. And we as healthcare professionals, we're here, you know, to listen to concerns and to provide ongoing education and engagement, and to ensure that understanding is achieved. And that might mean, you know, open communication, basically, ongoing support, maybe regular phone calls, face-to-face. And as I always say, we're here to help you assist in adjusting to the change. And as I always say, it's one day at a time. And the people that are reluctant to use it, I always advise, use it around the house, get used to the equipment, and then hopefully you'll find the benefit of it, and then you'll start venturing out. And then I'm going on now, just I think in conjunction with oxygen therapy, it's important that I mentioned just managing breathlessness. And breathlessness, it's a frightening symptom. And when you have pulmonary fibrosis, breathlessness is one of the symptoms that's attached to that. However, unhelpful thoughts can seep in. For instance, you could be doing an activity and that makes you breathless, and that can put a fear onto you. And therefore, that unhelpful thought may exacerbate that, do you know what, I'm going to stay away, because the natural thing to do is to avoid doing that activity. And in time, less activities might be taken because you fear the breathlessness so much. But in turn, your muscles are getting weaker, and weaker muscles take up more oxygen, and that can lead to further anxiety. And it's important to note as well, not everyone that has breathlessness will need oxygen therapy. So whether you're in oxygen therapy or not, it's important to learn ways for you to manage your breathlessness, so that you're in control and also have an improved quality of life. So I suppose I'll start off with just CBT. And that is, a lot of professionals have got training in that, and it's becoming more and more popular. And it's a tool that's used to help understand the relationship between the negative thoughts and the behaviour, particularly in breathlessness, as it can increase panic and escalate fears. The little handheld fan, this is a really cheap initiative, and really it has been demonstrated to relieve breathlessness as it cools the nasal and the oral mucosa receptors. And like that, you can have it on your person if you're going for a walk or with out exercising. And then pulmonary rehabilitation, or any kind of structured exercise. Not only does this have psychological or physical, but it also has psychological benefits. It does reduce breathlessness, it improves mood, and it also improves functional ability. The exercise maintains the muscle strength, so it hopefully will prevent the deconditioning, which is another term of losing muscle, and it can also improve confidence. Positioning during episodes of breathlessness can be very beneficial, as it you learn ways in which your breathing muscles can get into a better position so that you can breathe better. As well as that, you've got breathing techniques and relaxation, and there's multiple apps available that can slow the breathing down, and your physiotherapist as well can give you different techniques on breathing techniques. And then finally, medication. So medication, again, low dose morphine, anti-anxiety medications, they can also play a role in managing breathlessness. And just lifestyle modifications. So if we talk about lifestyle modifications, it's all about preserving energy, conserving energy. And when we talk about conserving energy, we're not saying avoid doing things. We'd recommend that you find a smart way to do things. And how you to do that is prioritize. Prioritize your energy. What needs to be done? Can it wait till tomorrow? Can someone help you to do it? And the reason you prioritize your energy is so that you have energy left to do the things that you enjoy. Planning. Plan your day, plan your week. If it's a case that you've got an appointment at 9 o'clock in the morning, can you get it pushed back to a time that suits you? Because you don't want to be rushing, because if you rush, you might start panicking. If you start panicking, it could exacerbate your breathlessness. So planning is very important. And finally, pacing. Pacing is so important because you need to be able to pace your activities, pace your day. I had a man in a few weeks ago, and he cut his grass for the first time this year, and he was very frustrated in himself because he had to stop twice to cut the grass. And we discussed about pacing, and we're like, maybe you cut one half of the grass, come in, have a cup of tea, and go back out and cut the second half of the garden. At the end of the day, the grass is cut, and there's that sense of achievement, but it's about trying to change the lifestyle, that everything doesn't have to be done today, it can wait. And just in summary, just to let, it is a drug, and it's individualized to your needs, which can change, and that's why it's important to have ongoing oxygen assessments. Communicate with your health providers if you're going on holidays or if you've got an issue in relation to safety. And as I say, adhere to the safety precautions, and also being able to manage the breathlessness along with your oxygen therapy will improve your control and your quality of life. Thank you.
Thank you so much for that, Carol. I really appreciate it. That was really, really informative. And just to say, we are out of time, but there is just this one question, if you've got 30 quick seconds. Is there any sun protection that you would recommend that is compatible with oxygen therapy? Any particular brands?
I'm not 100% sure. I would have to get back to you on that one.
Okay, great.
Yeah.
Well, thank you. Thank you so much for that. Thank you as well to all of our speakers for the informative presentations today. As I mentioned at the start of this session, this Patient Information Days are funded by our generous donors. And if you would like to donate to the Irish Lung Fibrosis Association, you can do that by going to our website, ilfa.ie, or you can send a check to our Brunswick Street address, which you will also find on the website. So thank you so much, everyone, and I hope you have an absolutely wonderful day.